Dr. Majmudar is an assistant professor of pediatric neurology here at Indiana University School of Medicine and Riley Hospital for Children. She completed her medical school at the University of Cincinnati College of Medicine in 2013 and her postgraduate residency training in pediatric neurology at Washington University School of Medicine in St. Louis and the St. Louis Children's Hospital in 2018. She's a board-certified neurologist with special qualification for child neurology, and she subspecializes in neonatal neurology. With this, she does both prenatal and fetal consults with our OB and maternal fetal medicine team, and as well as her neonatal consults within the NICU. And she follows these infants in early childhood period in the outpatient clinical track neurodevelopmental outcomes. Welcome.
Okay. Can you hear me? Yes, no? Can you hear now? Okay, just move ahead. All right. So yeah, thank you so much. So as you heard, I'm a neonatal neurologist. So that involves seeing consults on the prenatal side, as well as neonatal side in the NICU. So these are some of the most common causes of hydrocephalus that we get consulted for. On the prenatal side, most commonly we see congenital aqueductal stenosis, and a little bit less commonly genetic cause with X-linked hydrocephalus. And then on the neonatal side in the NICU, most common cause we see is post-hemorrhagic in the premature babies who've had intraventricular hemorrhage. And as you can imagine, we're talking about neurodevelopmental outcomes. Those are going to vary depending on the cause. I would say the great majority of patients that I follow in clinic that have hydrocephalus are going to be post-hemorrhagic due to IVH in the setting of prematurity. So in terms of looking at the outcomes today, I'm going to focus on that neonatal period and post-hemorrhagic hydrocephalus. So we've already heard a little bit earlier this morning about IVH and post-hemorrhagic hydrocephalus. So just to give a little bit of a review, IVH is clinically graded from 1 to 4, and the higher grades 3 to 4 are more likely to be associated with post-hemorrhagic hydrocephalus. And we see this in about up to a third of preterm infants who have IVH. And so in terms of thinking about this, once you've had IVH, there's been injury to the brain tissue. So trying to piece out in terms of the outcomes, how much of that is related to injury from the IVH itself versus the hydrocephalus can be a little bit difficult. But there have been studies looking at post-hemorrhagic hydrocephalus in and of itself, and it's associated with poor outcomes than in those patients that have IVH and don't develop hydrocephalus. So it's thought that hydrocephalus kind of further exacerbates injury that's already there from the IVH in the developing neonatal brain. And a lot of this has to do with white matter injury. So when you have white matter injury in the setting of IVH, you tend to have poorer outcomes than if you've had IVH without it. And in patients that have post-hemorrhagic hydrocephalus, they tend to have more white matter injury. And so it's thought that the white matter injury is what contributes to those worse outcomes that we see in hydrocephalus through inflammatory and other damage. And when we look at patients who have IVH and post-hemorrhagic hydrocephalus, increasing ventricular size adversely affects outcomes. So there's a study that compared those that have high-grade IVH 3 to 4 that did not develop hydrocephalus versus those that developed hydrocephalus that did not progress and did not need any surgical intervention to those that developed progressive hydrocephalus and then eventually required surgical intervention. And those that required intervention had worse outcomes in terms of motor, cognitive, and language at 18 to 24 months. and progressive hydrocephalus that ended up requiring surgical intervention were the most adversely affected out of all of the groups. So in terms of thinking about the outcomes, there can be effects on motor, so motor delay, impaired mobility and ambulation, so things such as cerebral palsy, cognitive dysfunction, so intellectual disability, behavioral issues, which can include autism, and then sensory dysfunction with vision and hearing impairment, and then of course seizures and epilepsy. And there's a study that looked at children aged 4 to 12 years who had had hydrocephalus as infants, and about half of them had learning disabilities, about a third had CP, and then a third had epilepsy. And in terms of looking at the different causes of hydrocephalus, those that have post-hemorrhagic and genetic causes tend to have the most adverse outcomes compared to other causes, including tumor, trauma, infection, et cetera. So this was a study that actually got published earlier this year from China and looked at infants who had had post-hemorrhagic hydrocephalus with a median follow-up time of about 3 years. And the kind of mild, moderate, severe deficits that are listed here are based on a standardized score called the Pediatric Stroke Outcome Measure. And this looks at motor function, sensory function, language, cognitive, and kind of breaks it down. And that's how they created these kind of level of deficits with mild, moderate, and severe. And so we can see that there is a difference when you see white matter injury versus not seeing white matter injury. So this second column here is those that had white matter injury when looking at MRI. And those had more significant deficits compared to those that did not have white matter injury, which is the top here on their MRI, which goes back to what we talked about earlier, that it's thought that it's this white matter injury that results in these more adverse outcomes. And this was done out of China, so there can be some variation if we look at different countries, but I think that the overall kind of message here is that a good chunk of patients who have post-hemorrhagic hydrocephalus do tend to have significant disability. And even those that didn't have white matter injury, more than half of them had moderate to severe deficits. So there's a post-hemorrhagic hydrocephalus workshop that was held at the NIH several years back. And they actually published a paper looking at kind of different opportunities for research. And one of those sections was looking at improving outcomes. And this is a few years old, but these are some of the things that they thought of in terms of research opportunities to improve outcomes for the future. And I wanted to go over a couple of patient cases. So this first one is GH. He was born at 25 weeks, had bilateral high grade 4 IVH, developed post-hemorrhagic hydrocephalus, had a VP shunt placed. He did have seizures when he was in the NICU, and he does currently have a diagnosis of epilepsy, but he's only on 1 anti-seizure medication at a low dose and remaining seizure-free with that. When I saw him initially at about 3 months, he had low axial tone, increased tone in his extremities, and then at 6 months, similar findings, but especially had motor delay. And then I ended up diagnosing him with cerebral palsy at about 10 months corrected age. And this mom was gracious enough to share some pictures of her son for us. So on the left is shortly after he got home from the NICU after a very prolonged stay. And then the second one is more recently. And it's hard to tell in the picture, but his head control has improved. He's doing pretty good with that, but he's still not able to sit up on his own. When I talked to her on the phone a couple of days ago, he's about 15 months corrected now, and he just recently started rolling over. He also does have cortical visual impairment, and so he does follow with ophthalmology as well. And then this is another example. So this is HD. He was born at about 28 weeks, had right grade 4 and left grade 3 IVH. Again, developed post-hemorrhagic hydrocephalus, had a shunt placed. He has had 1 revision so far at 22 months. And then when I saw him initially at about 4 months, kind of similarly to the previous patient, had low axial tone, increased tone in his extremities, motor delay, Saw him again about 7 months, similarly, even more motor delay. But he is almost 2 years old now, and he has mild CP, and he actually is able to walk with assistance. So does have orthotics and uses a gait trainer. These pictures are actually not of him, but I thought the first picture on the top there is pretty similar to how he was when I last saw him in clinic. So he was able to maybe take a few steps independently, but did require some assistance. He does not have any seizures. He did have to get strabismus surgery, and he's been wearing glasses since he was under a year old, but no hearing issues. And he actually is able to say some single words, working on putting 2 words together. He's very social. And then we're planning on getting a more detailed developmental assessment with the Bailey once he turns 2. So I tried to pick kind of 2 similar cases from my patients who were both pretty premature, had bilateral high-grade IVH, had hydrocephalus, needed shunts. But you can see a little bit of the range of outcomes that we can see there. So for the first one, I'm not sure that we're going to be able to get him to walking. But for this particular patient, he's doing pretty well and able to walk at least with assistance. So, and a lot of this I think also has to do with kind of early interventions and such as well, which kind of emphasize the importance of that as well. So yes, I will leave it at that. But thank you so much for inviting me to talk today. I really appreciate talking to you all.
Thanks.